For more than a decade, Farxiga, dapagliflozin, has been trusted again and again and again. Now's the time to choose Farxiga for your patients. Farxiga. To view clinical and safety information and see what makes Farxiga different, visit farxiga-hcp.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, CardioNerds. My name is Rick Ferraro, and I'm an advanced cardiac imaging fellow at the University of Michigan and contributor here at CardioNerds. We have an incredibly exciting episode to get to, and I couldn't be more excited to introduce our FIT Fellow in Training lead for the episode, Dr. Georgia Vasilakis Tsatiris, a chief resident at the University of Pittsburgh Medical Center. Welcome, Georgia.
Thanks so much, Rick. We're delighted to extend the warmest welcome to our faculty expert for tonight's episode, Dr. Justin Grodin. Dr. Grodin is an associate professor in the Department of Internal Medicine and Division of Cardiology, as well as the medical director of the Internal Medicine Clinical Trials Unit at UT Southwestern. He earned his bachelor's degree in chemistry from UT Austin, and both his medical degree and internal medicine residency training at UT Southwestern. He completed both his general cardiology fellowship and advanced heart failure and transplant cardiology fellowships at the Cleveland Clinic. Dr. Grodin also holds a Master's of Public Health from the Harvard T.H. Chan School of Public Health. He splits his professional time with a clinical focus in advanced heart failure and therapies, including cardiac amyloidosis, and a research focus in heart failure outcomes as a clinical epidemiologist. Among his many hats, he even serves as a site PI for international registry studies for TTR cardiac amyloidosis. Thank you so much for joining us today, Dr. Grodin.
Thank you for having me. It's a pleasure to be here.
Awesome. Thank you so much, Dr. Grodin. It's going to be a great conversation. And so I want to start by, this episode is really about treatment, but ATTR, amyloidosis and cardiac amyloidosis, both in diagnosis and treatment, is a very active area of research over the last decade, as I'm sure we'll discuss. And way more than Congo red stains that we learned about in medical school is part of the picture. Treatment advances in the field have challenged the standard guideline-directed medical therapy, or GDMT regimen, that we've all learned about in training. And as we've discussed in earlier episodes in this series on the biology and diagnosis of ATTR cardiac amyloid, this is a progressive disease, and patients can present to us at really any given stage of that disease process. Dr. Grodin, how do you sniff out cardiac amyloidosis from the typical heart failure patient or HFpEF patient? And what makes you more suspicious, or how would you counsel fellow CardioNerds to do the same?
Well, I think the first thing and the most important thing that I teach all of my residents and fellows, and, when I give a lot of talks is, you really have to have a strong index of suspicion. What do I mean by that? I mean that you have to think that a patient could have amyloidosis. If you don't cross that barrier, then you're never going to diagnose it. So once you're there, I really think that there's some pretty straightforward, simple clues. And I think the one clue that definitely resonates and is really simple that a lot of budding cardiologists such as yourselves will identify is somebody that has very thick heart muscle that is disproportionately thick to the voltage on their electrocardiogram. So there is a little bit of there's a dichotomy there, right? So typically with a patient who has conventional LVH from hypertension or other comorbidities, we would typically see a high voltage pattern on the EKG. In a patient with amyloidosis, it is more common that we don't, and we see what's called a disproportionately low voltage on the ECG. And for some patients, they may have a classic low voltage ECG. That's really one of the simplest, most straightforward clues or red flags, if you will. But then there's some other enhancing factors that will help build a case to support a diagnosis of amyloidosis in one of our patients. We look at a lot of musculoskeletal or non-cardiac manifestations that could serve as clues that that's what a patient has. The first of these is bilateral carpal tunnel syndrome. Bilateral carpal tunnel syndrome is quite common. However, it's estimated that about 1 in 10 patients over the age of 65 that have bilateral carpal tunnel syndrome actually have amyloidosis. Now, I think anybody who has a thick heart muscle, who has previously tolerated antihypertensive medicines, or who is not hypertensive and might even be hypotensive, that also is not consistent with what you would normally think of, that could also be a clue that somebody has amyloidosis. And then I think there's some other clues that are perhaps less common. I think anybody with an unexplained neuropathy that has thick heart muscle, that should really serve as a clue that they might have cardiac amyloidosis. Anybody with a atraumatic biceps tendon rupture, this is a major red flag that somebody may have amyloidosis. Spinal stenosis is also another associated symptom, and the tenosynovium of the lumbar spine has also been demonstrated to stain Congo red positive, indicating the presence of amyloidosis. And then I think one thing that's also can be reasonably common, we also see cardiac amyloidosis concomitant with other diseases, the first of which is hypertrophic cardiomyopathy that occurs over the age of 65. This should also serve as a red flag. And then we also see a fair amount of amyloidosis in patients with aortic stenosis. So it's estimated that about 10 to 15% of patients with critical aortic stenosis also have concomitant amyloidosis.
Wow, that was an incredible overview. And I think it really helps us put together in our mind's eye what cardiac amyloidosis really is. So putting all of that together, let's take a trip to the CardioNerds amyloidosis clinic. Perhaps this is a patient that you would see in your PCP clinic or maybe in your continuity clinic as a fellow. So Mr. Taylor Famidis is a 70-year-old male with hypertension and hyperlipidemia who presents to your clinic with a few months of worsening dyspnea on exertion. He walks into your exam room with a slight bend forward and shares that his fingers sometimes get numb. He also reports feeling like his heart skips a beat occasionally and feels lightheaded and dizzy when getting up too fast. On your physical exam, he has a brisk systolic ejection murmur, and he shares with you that his father passed away from his heart, but can't really share much more. He was tried on low-dose beta blockade a few months back, but stopped taking it because it caused profound dizziness and even a fall. So if you were precepting this patient in clinic, Dr. Grodin, or you were seeing them yourself, how would you work up this patient for cardiac amyloidosis?
Well, I think you present quite a compelling case, Georgia. And I think the first thing is getting routine electrocardiography and getting an echocardiogram. And as I mentioned before, I would really want to start there to see if there are any clues that this person could have thick myocardium or perhaps disproportionately low voltage on their ECG.
Great. And so after you get an ECG, would you send this patient for further testing, like imaging, lab work, things like that?
Yeah, I think once you've had those assessments and you have this index of suspicion, just like this sample patient that you've been discussing, then I think what's really, really crucial is that of at least we think the 11 types of amyloidosis that can affect the heart, there are two that are very, very common. In fact, they make up anywhere from 95 to 99% of all the cases of cardiac amyloidosis. And those are AL, or for amyloid light chain, and then ATTR, or transthyretin amyloidosis. And of those two, light chain amyloidosis is a critical diagnosis to make. So really one of the most important things that we can check when we have a high index of suspicion for cardiac amyloidosis are serum-free light chains and then urine and serum immunofixation. And what we want to do is hopefully either rule out or rule in AL amyloidosis. Now, in addition, I will also get standard chemistries, a liver function panel, and then also NT-proBNP, cardiac troponin. I tend to get a pre-albumin because that is actually measuring TTR, but that's something that's a little bit more controversial. I'm a biomarker researcher, so I find those things interesting, but it's not absolutely necessary to get. And then I would also get a complete blood count. So I would start there. Now, if let's say we have ruled out AL amyloidosis, that is to say that the serum-free light chains and then our serum and urine immunofixation data are negative and they do not identify an abnormal M protein, then this allows us to achieve a non-biopsy type-specific diagnosis of cardiac amyloidosis. And the way we do that is with a bone tracer using cardiac scintigraphy. So there are a number of bone tracers. The kind that we use here in the United States is technetium pyrophosphate. And this is quite a straightforward scan where planar images, at least at our institution, are taken after 1 hour of injection. And then we get a SPECT imaging at 3 hours. Now, if that's positive, that can confer a type-specific diagnosis of ATTR amyloidosis. However, if we cannot rule out AL amyloidosis and we do find evidence of an abnormal M protein, then there really is no non-biopsy diagnosis for this disease. At that point, the diagnostic pathway of preference is really securing tissue. Now, the tissue that we secure is typically the target organ. I can tell you at our institution, we typically biopsy the endomyocardium. So we do endomyocardial biopsies. Now, other target organs are also available for biopsy. Some institutions will do fat pads, and the yield with a fat pad biopsy can be different at different institutions because it can be variable in how the samples are accessed and how they're prepared. And then any other target organ that could have evidence of infiltration.
So clearly, there is so much that goes into making the diagnosis of cardiac amyloidosis. Thank you for such a thorough discussion. And even for Mr. Tafamidis, y'all see what I did there? Couldn't help myself. But in all seriousness, it certainly requires a multidisciplinary team thinking about amyloid in the general population. And the combination of invasive and non-invasive diagnostic workup can be shared by cardiologists, PCPs, and other subspecialists alike. And we know now that the standard GDMT recipe, if you will, is not well tolerated in the ATTR population, given the differing physiology of restrictive heart failure versus HFrEF. So, Dr. Grodin, we'd love to discuss a bit more. What treatment options do we have to offer now for ATTR? And how is this compared to years prior?
Well, I'm really glad you asked that question. So now that we're focusing a little bit more on ATTR cardiac amyloidosis, this was largely thought of as a disease that most clinicians really never wanted to diagnose because, Georgia, as you quite accurately put, there were no treatments really until 2019 with the FDA approval of an agent called tafamidis. Kind of sounds a little bit like your patients that you're seeing in the CardioNerds clinic. We really had nothing before 2019 outside of cardiac transplantation for individuals with really advanced disease. Now, for patients with ATTR polyneuropathy, historically, they used to do prophylactic liver transplants. And the idea being that the TTR is synthesized in the liver, and if you swap it out for a liver that makes our wild type TTR, you would halt disease progression. As you can imagine, that's quite a morbid procedure and really wasn't available for individuals that, one, don't have hereditary disease, or two, don't really have neuropathy or who might have cardiomyopathy and really can't tolerate a liver transplant alone. So with 2019, we've really had this surge in the interest of this disease, and it's largely been because we now have treatments. When we talk about the treatments of ATTR amyloidosis, I think it's really important to understand the amyloidogenic cascade. So how do amyloid deposits form? So the TTR that deposits in the myocardium is formed in the liver and then circulates in the bloodstream. When I'm seeing a patient, I usually explain that we have really two main mechanisms by which we treat this disease. The first is we halt or slow ATTR disease progression by stopping deposition. Then the second of these strategies is to clear amyloid deposits. I like to start with the first strategy before we move on to the second. So the first strategy, we really have two ways where we can stop the production of amyloid deposits. There were seminal discoveries made approximately 25 years ago where there were these individuals that were immune to developing ATTR amyloidosis when it was so common among their family members. And genetic analyses demonstrated that they had a super stabilizing mutation. So scientists then discovered that this mutation increased the energy of TTR dissociation, that is to say, where the tetramer doesn't break down into its 4 individual monomers and then causes the disease. And so they found that these super immune individuals had these thyroxine binding sites that would be super stabilized, and then the protein never dissociated and never formed amyloid. So then they found that small molecules that can either mimic this specific mutation or that can bind to these thyroxine binding sites could treat the disease. The first of which is a benzoxazole derivative called tafamidis. And tafamidis is an oral drug. It's administered once a day. And in the ATTR clinical trial, it was demonstrated to improve both morbidity and mortality in patients with ATTR cardiomyopathy that was either hereditary or wild type. And that was largely the only drug that we had up until just a few months ago. In November of 2024, another TTR stabilizer called acoramidis that works in a similar way to tafamidis, but is a near complete stabilizer of the TTR tetramer, also was approved by the FDA. And in its clinical trial called ATTR-CM, it was also demonstrated to improve both morbidity and, with their long-term follow-up data, demonstrate an improvement in mortality. So both of those agents are pills, and they stabilize the TTR tetramer as treatment for ATTR cardiomyopathy. There is another class of agents that halts or slows the progression of the disease, and we call these TTR silencers. So what do I mean by that? So these are agents that either have to be injected or infused that inhibit the liver's production of TTR in the bloodstream. So in some ways, it makes the circulating TTR in the blood knock down anywhere from 80 to about 90% of its pre-treatment level. So it's almost undetectable. Now, these agents are really fourfold. We have the ones that are currently FDA approved are antisense oligonucleotides or small interfering RNAs. The antisense oligonucleotides that are approved are agents called inotersen or eplontersen. Inotersen and eplontersen are currently only FDA approved for ATTR polyneuropathy. There is an agent that's infused, it's an siRNA called patisiran. Patisiran is infused every 3 weeks. That too is only approved for ATTR polyneuropathy. And I should mention that those other 2 agents and patisiran are only approved for hereditary ATTR polyneuropathy. Then the last agent, which I'll get into in a little bit more detail, is called vutrisiran. This is administered subcutaneously every 3 months. And vutrisiran is a wonderful drug. It's currently approved for ATTR polyneuropathy that's hereditary now, but there was a recent clinical trial that demonstrated a benefit on both morbidity and mortality in patients with ATTR cardiomyopathy. And we hope, and I'd like to expect that drug, we'll see what the FDA thinks, will get approved sometime in the spring of 2025. So those are the current agents, and then the rest are investigational. Now, this other big bucket that I was highlighting was agents that clear ATTR. And if you're interested, I'd be delighted to talk about things that are on the horizon and drugs that are investigational. But at this point, the only therapy to clear amyloid deposits or ATTR amyloid deposits is organ transplantation.
Wow, Dr. Grodin, that was really incredible. I think I'm going to have to listen to this again at like half speed because everything you covered there was was really amazing. And as you mentioned, so much has changed. I remember one of the first things, I remember being on medicine rounds when tafamidis came out in 2019, or was approved by the FDA in 2019. And in the amount that it has happened since then, it's just incredible. And so I really appreciate you giving us kind of a roadmap overview of all that. One thing that I want to discuss a little more, and you had mentioned this or touched upon this a little bit in your discussion of some of the medications that are available, is the role of genetic testing in these patients as well as family members. How does that impact treatment options, and how do you use that in your practice?
Well, I think I'll answer the last question first. How do I use genetic testing in my practice? So for ATTR, I consider it standard of care. We sequence everybody. And as it turns out, age and family history really aren't good, reliable markers as to whether somebody's got hereditary disease. So sometimes you just don't know, or there's a substantial amount of recall bias, or simply put, maybe the disease was not diagnosed. So we do genetic testing in everyone. And then, as you did allude, it does have implications for treatment, but I also think it has implications for family screening. And I'll talk about family screening first. And I think family screening is very important. So typically when we get genetic testing, if we do find that somebody has a pathogenic or likely pathogenic variant in the TTR gene, we do refer them to genetic counseling where they can get, educated about the GINA Act, implications for life insurance, and then offer the ability to do cascade screening on family members. And why is that important? Because different family members can be affected differently. We know that this is an autosomal dominant disease, so it's quite common. And we know that penetrance can occur at different ages amongst your patients. So it really is a cornerstone of my practice. And then, as you mentioned right now, I think if you ask a lot of clinicians that treat this disease, scientifically, all of the treatments should work for ATTR. I mean, they're treating the protein and they're inhibiting amyloid deposits. They're not necessarily directly treating the organ. But right now, genetic testing is really crucial to get treatment because of FDA labeling. As I mentioned, for a patient to get a silencer or an agent that silences the hepatic production of TTR, they have to have hereditary ATTR with polyneuropathy. They can secure these agents if they have concomitant cardiomyopathy, but they must have polyneuropathy and a pathogenic variant. Now, the stabilizers, on the other hand, tafamidis and acoramidis, they're approved for ATTR cardiomyopathy, whether or not a pathogenic TTR variant has been detected. So right now, it's largely a labeling issue. I can tell you in the future that might be a thing in the past, and hopefully we don't have to wait too long.
I was wondering if you are noticing any treatment response differences between the wild type and hereditary folks, or any differences between men and women.
Yeah, so I think those are good questions. I think for your first question, do we see treatment differences with hereditary and wild type? I can tell you that a lot of epidemiological data suggests that patients with variant ATTR have a more aggressive disease. So there's no question that basic science studies demonstrate that these treatments inhibit fibril formation, whether or not the protein is mutated or is wild type. So there's no question that these drugs work. I think really when we see these treatment differences, so to speak, I think it really depends on where the patient is within the course of their disease. If we start treating them later in their disease course, these drugs, because they don't cure the disease or rid the organ of the amyloid fibrils, they really just halt or slow the disease. There's really not much disease stabilization that they can benefit from if it's in a severe state. And I think a lot of data demonstrates that individuals diagnosed at earlier stages may secure a greater benefit. And I think that makes sense because later stages of these disease, prognosis can be driven by chronic kidney disease, frailty, malnutrition, other organ systems that have been affected. It really becomes multifactorial. So I've kind of turned your question into really a PSA in really trying to diagnose this disease as early as possible whether it is hereditary or wild type ATTR, to try to get as much of a therapeutic impact from these therapies as possible. And then now, when you talk about do women or men achieve a different benefit, I can't tell you that I've ever really seen a difference in benefit from these drugs. Indeed, the majority of my patients are men, but I don't know that I've seen a differential response. And then the data from the clinical trials at least doesn't support that there is a different response to these therapies among the different sex groups.
Thank you so much for sharing all of that, Dr. Grodin. I have one more question on the topic of the genetic testing. What about genetically modified treatments, things like CRISPR-Cas9? I remember it being part of a theory that we learned about in my intro to biology class like 10 years ago. And I just wondered if you had any thoughts on the role of the advances in CRISPR-Cas9 in helping our patients.
Okay, now, Georgia, you're getting into the fun stuff. I mean, it's all fun, but now we're getting into the really, really fun stuff. So I'm delighted that you asked that. You mentioned CRISPR-Cas9, which is single base pair editing. And there is an agent that has been developed and is currently in clinical trial testing called NTLA-2001. It's currently in a phase 3 clinical trial. Now, what this agent does is it is administered in an infusion and only given one time, and it silences the hepatic production of TTR indefinitely, or at least we think indefinitely. So you're exactly right, Georgia, that what you've heard is correct. And ATTR amyloidosis is a really elegant disease model to test a therapy such as this because it is one gene, one protein, one disease. So it really is an ideal disease to test a therapy that has been created on the platform of a CRISPR-Cas9 based technology. So that clinical trial is currently underway, and we'll be hopefully receiving promising results in the years to come.
So much to look forward to. I mean, as Rick was talking about earlier too, since 2019, there's just been so much change in how we even think about cardiac amyloidosis, let alone the treatment. And so it sounds like in the next 10 years, we'll have an even wider variety of treatment options for our patients. And I think that's so, so, so cool. In the meantime, though, there's other symptoms of amyloidosis that are a byproduct of the misfolded proteins. And I was wondering how, for us who are still in internal medicine like me, how we can best call on our friends and other subspecialties to take care of the concomitant diseases like peripheral neuropathy, symptomatic AFib, aortic stenosis, and do any of the ATTR-specific treatments show improvements in these manifestations?
So that's a great question. There's no question that taking care of patients with ATTR amyloidosis really does, for a number of patients, a really need a multidisciplinary care model. And I think you alluded to that earlier on in this discussion. And I think one of the clues that you had of your patient, Tay Famidis, it sounds like this person had carpal tunnel syndrome. So, we do refer our patients a lot to hand surgeons. And then I do collaborate very closely with neurologists, specifically those that are, neuromuscular inclined, but they don't have to be, that can help manage the peripheral neuropathy that these individuals may or may not experience. Then a number of these patients also have autonomic dysfunction. So that can be an added benefit of seeing a neurologist who has expertise in taking care of patients with autonomic dysfunction, because there might be some strategies to help increase their blood pressure or different maneuvers that can mitigate symptoms of autonomic dysfunction. A number of my patients also see electrophysiologists. I think you alluded to atrial fibrillation. So atrial fibrillation and atrial flutter are not uncommon in ATTR amyloidosis. So I typically do collaborate very closely with electrophysiologists. And then a number of my patients have to see gastroenterologists, because especially if they have an autonomic dysfunction or an autonomic neuropathy, they may have issues with gut motility. And then we also see that for a number of our patients with wild type ATTR, the constipation can be a very big problem. And then ATTR is also a disease of aging, in particular ATTR wild type. So I do collaborate very closely with geriatricians, because I think what's really important when you look at registry data of patients with ATTR, you'll see that the majority of the patients that we diagnose are in their mid to late 70s. And I think that's very important because for those individuals, we have to really think about what they're trying to maintain for their lives. And mortality may not be the most important thing. They're trying to maximize self-efficacy, mobility, cognition, quality of life, and nutrition. And so interventions where we can maximize all of those are typically achieved with individuals with expertise in geroscience or geriatrics. And so I do collaborate with those individuals quite a bit.
Thank you so much, Dr. Grodin. Again, this has really been a fantastic discussion, and all the kind of pearls and wisdom and things to pick up on here have been really helpful. And I don't think when we were, like medicine residency, early years, 2019, 2020, I don't think we were thinking as much about things like carpal tunnel, right? And now I see biopsies that are being sent from patients with carpal tunnel, and we're diagnosing ATTR that way, which is really, really incredible. Kind of related to that, I'd like to ask you about management of subclinical ATTR and how do we better catch those patients, as you mentioned before, they get to kind of end stage cardiomyopathy. And then relatedly, or maybe even unrelatedly, just as a general question, what are some areas of additional promising research aside from what you've discussed thus far?
Okay, well, so the first question, I think you're actually asking a question that really is right in the crosshairs of my current research interest, which I think from the broader goal is to ask that question as to how do I identify this early? So outside of getting too much into the research world, simply put, having a strong index of suspicion. So the data really demonstrate that a number of patients with ATTR amyloidosis and any other type of amyloidosis are really on these like diagnostic journeys for months, maybe even years before they find a clinician that suspects this disease. So I think that's really the simplest thing that I can tell you. But then when we look at clues for subclinical ATTR, I think the first is genetic testing. We know that different TTR variants do occur or can be penetrant at different ages in life. The most common TTR variant that causes hereditary ATTR amyloidosis of the heart on Earth is very, very common in individuals with Western African ancestry. That is the V122I mutation, or currently now the PV142I mutation. So they're the same nomenclature. It just has to do with the promoter region. So this variant is present in 3 to 4% of everyone with Western African ancestry on Earth. So it is quite common. For example, we suspect that there are over 1.5 million carriers of that variant in the United States alone. And all these individuals are at, we think, a 1.5 to almost twofold, maybe even threefold, depending on which data you cite, greater risk of developing heart failure than age, sex, and race matched non-carrier controls. So right now, the way that we manage these individuals, so they're genetically at risk, is, I think it's symptom driven, very simple. There's been a expert consensus statement that suggests you start monitoring these individuals about a decade before the proband or somebody that had the disease in their family. So let's say that, dad had hereditary ATTR at the age of 70. We would start screening family members around the age of 60. Now, how you screen, I think it's got to be practical. I do standard things like the workup we mentioned, ECG, echocardiogram, blood work. And then if we're starting to build a higher index of suspicion, that's when I'll get into some more, specific amyloid testing. I think that's the first thing. And we could go into even more detail. I mean, I'd love to tell you about our NIH-funded research if you're interested. But I think you also kind of want to know what is on the horizon. So I think the first thing is that there is going to be a clinical trial that I don't know if it's open to enrollment yet, but will be soon, that for individuals that are in this critical early onset 10-year time window, There's a clinical trial called ACT Early, where these individuals are randomly assigned to acoramidis or placebo, and then they're being followed for the development of ATTR amyloidosis. So really, really exciting clinical trial. And that's really going to answer this crucial question, is whether or not treatment prior to symptom onset or disease onset can prevent amyloid disease. So I think that's one novelty. We've already talked about CRISPR-Cas9. And then a class of drug therapy that we really didn't touch on earlier are drugs that deplete or clear amyloid deposits. We call these the fibril depleters. And these are largely monoclonal antibodies that are targeting amyloid fibrils. So they are all in clinical trials, some in different phases of testing. There is a company called Alexion that has an agent called ALXN 2220 that is currently in phase 3 clinical trial. Novo Nordisk has a monoclonal antibody called coramitug. They are starting their phase 3 clinical trial very soon. And then Atralis is also developing a pan-amyloid fibril depleting agent. So this is really, really exciting. Some phase 1 data have been presented that are obviously promising, and it's really too early to tell, but we're super excited about those agents because they can offer to our patients really what they want to hear is the possibility of a cure and organ improvement.
Yeah, that's really cool, Dr. Grodin. Clearly there's a lot more going on, a lot more to learn, and hopefully a lot more than we can do for patients. If you have time, we'd love to hear a little bit more about your research, specifically if you're okay with talking about that.
Sure. I'd love to tell you a little bit about some of our research interests. So right now we have a large multi-center NIH cohort study. So here at UT Southwestern, we're the lead site. Cleveland Clinic and Columbia are also collaborators. And essentially what we're doing a nested case control study where we are taking known V122I TTR carriers that do not have heart failure, and we are comparing them with age, sex, and race-matched non-carrier controls that we are taking from the Dallas Heart Study, again, that we know don't have heart failure. Then we're also enrolling individuals who have bona fide V122I ATTR that is symptomatic. And then what we're doing is we're doing this kind of biomarker battery where we're looking at different biomarkers that indicate TTR biology, where maybe with blood tests, we could identify the presence or maybe this kind of like at-risk phenotype or molecular phenotype, if you will, of ongoing or early amyloidogenesis, which means formation of amyloid in the blood. We're also doing completely novel resting and exercise cardiac magnetic resonance imaging on these individuals where, they're getting a resting cardiac MRI with all the bells and whistles. We're using 3T magnets at every site, complete with contrast, parametric maps, and then strain in all 4 chambers. So really gorgeous pictures. And I mentioned they're 3T magnets, which is kind of like a high definition MRI of their heart. So super, super exciting. We've got a sub-study at UT Southwestern where we are getting them to exercise in the bore of the magnet. So unlike conventional stress tests that maybe you all and many of the CardioNerds listeners have experienced, there's this like song and dance where you have your patient on a treadmill, then they make your peak heart rate, and then we have to, in a very careful, quick, coordinated way, get them on the bed or on the stretcher and position them such that we can get cardiac imaging in an efficient way to see what's changed. So we totally avoid that limitation by having them exercise on pedals while they're supine in the bore of the magnet. So these pedals are completely pneumatic, and then we can increase their workload and we can see whether or not their heart exhibits a subclinical restrictive physiology as their workload increases. So we're super, super excited. We've enrolled about 140 patients thus far, and we hope to enroll for the years to come.
That's incredible, Dr. Grodin. I appreciate you taking us through that and so much of what is exciting and what is yet to come in this disease process. And again, really with the focus being on what we can do to help patients. I think we've discussed this a lot already, but a question that we ask everyone here at CardioNerds, and we'd love to ask you as well, is what makes your heart flutter about cardiology and ATTR in particular?
I like the pun. What makes my heart flutter about cardiology? Well, I can share with you all that I think, really since the start of fellowship and now with my job, I don't think I've worked a day in my life. I truly enjoy what I do. I think I enjoy all aspects. My love and enjoyment for my profession is really multidimensional. Obviously, I like taking care of patients. I like offering them something from my area of expertise that might help them, might comfort them, be there in patients' critical moments when they're scared or they're concerned, and, be able to answer their questions or perhaps put them at ease and give them hope for different treatment. And then I really enjoy teaching and engaging with trainees such as yourselves and the other cardio nerds, and then collaborating with colleagues. And then obviously, we practice in a field that I think is important. I think the great Jim Willerson, who is a famous cardiologist, put it very well, that he always wanted to do things that were worthwhile. And I think everybody and your listeners certainly agree that the practice of cardiology is definitely something worthwhile. And then I think with ATTR amyloidosis, to become a little bit more focused, think the outside of the patient care, I really enjoy taking care of the patients. It is a pleasure to offer specialty care to patients that are worried, that are concerned, and that are seeking an expert opinion. And then I really enjoy the collaboration. I think a lot of my colleagues, I know, Georgia, you highlighted your mentor at University of Pittsburgh, but it's really a tremendous group of people. And then it's also a field, as, hopefully both of you on this call and all of your listeners can appreciate, that it's really at the forefront, cutting edge of medicine. And there's so many unanswered questions. So it really gets me excited as an investigator to think about ways we can answer all these questions so that we can ultimately help all of our patients.
Thank you for sharing that with us, Dr. Grodin. It's truly inspiring to have somebody to talk to for this episode, not only talking to us as trainees and giving us inspiration and hope, but also talking about a field and such a wonderful area of expertise that you love. And so may we all find that in our careers. I've certainly enjoyed this fabulous discussion tonight. Thank you so much, Rick, for inviting me to be a part of this tonight. And thank you, Dr. Grodin, for giving us a framework to think about how we diagnose and how we treat ATTR, and an appreciation for all the work that goes into finding new, more advanced treatments for our patients. It certainly gives us a sense of pride in what we do every day. On behalf of all of us at CardioNerds, we thank you for your time, Dr. Grodin. I'm certain that we all learned something new tonight. I sure did.
Well, thank you, Georgia. Thank you, Rick, for having me. This has been an absolute pleasure, and I really applaud what all of you are doing. I think CardioNerds is fantastic, and it's definitely a highlight for me to contribute to everything you all are doing.
Thank you so much, Dr. Grodin.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Christiana Dangas. I'm an intern in the CardioNerds Academy and a senior at Boston University. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.